First of all, I would like to thank the organizing committee, especially Professor Magdi, for this kind invitation. In a few minutes, I will discuss the treatment of moderate aortic stenosis in patients with heart failure and reduced ejection fraction. Is it too early to be implemented? Over the past 6 decades, Eugene Braunwald has actually witnessed the great evolution of aortic stenosis management, proving the concept that he has succinctly phrased 6 decades ago, and I'm quoting his words: the most important decision in the management of patients with aortic stenosis is when to refer them to a timely intervention. So according to the ACCHA Guidelines 2020, moderate aortic stenosis is given a Class 2B indication to be treated when there's other indications for cardiac surgery like CABG or aortic surgeries. And last year, the valvular heart disease guidelines of the European Society of Cardiology has shown that SAVR, a surgical replacement of the aortic valve, is indicated only when the patient is undergoing CABG or surgical intervention of the ascending aorta. And the new concept also was introduced, which was the indication for intervention in moderate aortic stenosis combined with moderate aortic regurg in both symptomatic and asymptomatic patients. And especially in asymptomatic patients when the ejection fraction is below 50%, that is not attributable to other cardiac disease. The National Echocardiographic Database of Australia showed poor long-term survival in patients with moderate aortic stenosis. The 5-year mortality rate among those patients was close to that of severe aortic stenosis. In a study on more than 9,000 patients, it was found that moderate aortic stenosis, when combined with heart failure and reduced ejection fraction, was associated with reduced all-cause mortality, with higher all-cause mortality and higher composite of heart failure hospitalization and all-cause mortality. And interestingly, when we looked at the propensity matched score of those patients, it was found that the cumulative incidence of heart failure hospitalization per 100 patients, it was even higher for patients with moderate aortic stenosis compared to those with severe or having no aortic stenosis. And when they stratified those patients according to the ejection fraction, those less than 35% or those between 35 to 50%, it was found that the lower the ejection fraction, the higher is the cumulative event rates. And in this systemic review and meta-analysis of reconstructed time to event data of more than 400,000 patients, it was found that moderate aortic stenosis had 2.5 times the overall incidence of mortality compared to those with no or mild aortic stenosis, and especially if those patients also have reduced ejection fraction. Looking to the mortality curve over time, the varying time-related events, it is obvious that patients with heart failure and reduced ejection fraction had an incremental initial uprise in the mortality within the first few years, and then this curve tends to flatten and plateau later on. And the lifetime loss was estimated to be about 4 years for those patients. So the mortality burden of untreated aortic stenosis still exists. We can see here that the mortality in moderate aortic stenosis, the 4-year mortality, is approaching 33.5%, and those with moderate to severe aortic stenosis, it's about 46%. But interestingly, it was found that still the offering of aortic valve replacement, even in severe aortic stenosis, was low. It was only about 60%. So why is moderate aortic stenosis as bad as severe aortic stenosis? Well, this might be due to challenges in echocardiographic diagnosis, some sort of misclassification items, and also the conversion rate. It's still not obvious what is the rate of conversion and accordingly the rate of follow-up of those patients. So the challenges of echocardiographic diagnosis, you know that the overestimation of the velocity time integral, the correct alignment between the jet and the ultrasound beam, and that we know also the problems and the pitfalls with the continuity equations, that the LVOT is actually elliptical rather than circular in shape. So this gives us the concept of the discordant grading of the moderate aortic stenosis by transthoracic echo. When we find the aortic valve area is pointing to something, but the gradient and the velocity is making it a little bit intriguing. So in this case, we should offer multimodality imaging for those patients, like by offering them dobutamine stress echo, which if not feasible or inconclusive, CT has been offered as a very important tool in assessing the severity of aortic stenosis. Also, cardiac magnetic resonance imaging showing the fibrosis of the myocardium and what is called the extracellular volume expansion, and it was found that it has a relation to the all-cause mortality and cardiovascular mortality. Also, even in patients with normal ejection fraction by echo, speckle tracking echocardiography and assessment of global longitudinal strain might indicate the presence of subclinical left ventricular dysfunction. In this study, it was found that even in patients with an ejection fraction above 60% and impaired left ventricular global longitudinal strain below a specific cutoff value was associated with higher mortality among patients with moderate aortic stenosis. This is also another study that showed that in patients with moderate aortic stenosis, a reduced GLS below 16% identified patients with preserved ejection fraction who had a worse survival. The concordance of echo versus invasive assessment was assessed in a 15-year single center experience, and it actually showed that 30%, 1/3 of the patients who were originally classified by echo as moderate aortic stenosis were reclassified as having severe aortic stenosis. And thus, they suggested the implementation of what we call a refined thresholds for pseudo-moderate aortic stenosis that might improve patient selection and optimize the treatment timing. The second important issue is misclassification. So this staging classification scheme has been proposed for patients with aortic stenosis because we only look in aortic stenosis to the valve, but we have to look to the extravalvular criteria of cardiac damage. So stage 0 is just mere aortic stenosis without damage. Stage 1 when there is left ventricular damage. Stage 2 when there is left atrial or mitral damage. Stage 3 when there is pulmonary artery and tricuspid damage. And stage 4 when there is right ventricular damage. In this study on almost 1,200 patients, it was found that almost 70% of patients with moderate aortic stenosis lie in the category of group 1 and 2 in the staging system. And it was found that the higher the stage in the scheme of the staging of or classification of moderate aortic stenosis, the higher is the all-cause and cardiovascular mortality. Looking to the recovery of these stages after aortic valve replacement. Actually, it was found that there is only improvement in 15% of the patients 1 year after the aortic valve replacement, while there is no change in almost 58% of the patients and even worsening in about 1/4 of the patients. And the predictors of the 1 year worsening in cardiac damage was actually hypertension and surgical aortic valve replacement. And this impacted the 2-year outcomes of all-cause mortality and cardiovascular mortality. Also, NT-proBNP as a biomarker is a very important tool that has to be assessed among patients with moderate aortic stenosis. It was found that the mortality significantly was higher in patients with a higher NT-proBNP even after aortic valve replacement. The third issue is the conversion rate, which is still not very obvious. The guidelines recommend that patients with moderate aortic stenosis should be followed up every 1 to 2 years. But this actually has been intriguing and has been readdressed, suggesting that more closer follow-up intervals would be mandated. In this retrospective longitudinal cohort study of 540 patients, it was found that the progression of aortic stenosis is kind of individual and following a linear pattern. Faster progression was associated with higher age, AFib, patients with CKD, patients with left ventricular mass index, higher left ventricular mass index, and it was associated with worse outcomes. So they came up with a kind of progression rate calculator. Accordingly, we can tailor the follow-up of the patients based on the progression rate. And even artificial intelligence has been proposed as a tool to assess the progression of aortic stenosis with a high accuracy, high sensitivity, and specificity. Is there a drug that can curb the progression of aortic stenosis? In this phase 2 randomized trial that tested a drug that reactivates oxidized soluble guanylate cyclase, ataciguat, it was found that it reduced the progression of aortic calcification by almost 70% over 6 months. Although it missed clinical significance, but it was actually a very interesting finding that will be tested in further phase 3 trials. So coming to the fact, is moderate aortic stenosis with cardiac damage a new type of severe aortic stenosis? And accordingly, should it be treated? In this study, of a 10-year outcome study, it was found that patients with moderate aortic stenosis who received aortic valve replacement did better in terms of cumulative survival compared to those undergoing only clinical surveillance. But when we look deeper, we found that when stratified by the ejection fraction, those who benefited were actually those with an ejection fraction above 50%, while those with ejection fraction below 50% showed no significant difference either in cumulative survival, in all-cause mortality, or in terms of cardiovascular mortality. The ATLAS-TAVI trial showed that TAVR patients with reduced ejection fraction and non-severe aortic stenosis, when they were offered TAVR, they did better at 1 year and 2 years compared to medical therapy alone. And in this study also, propensity matched a cohort study on moderate aortic stenosis in patients with HFrEF, it was found still also that despite the outcomes with moderate aortic stenosis was worse, yet when they were matched regarding aortic valve replacement versus conservative treatment, there was a kind of also significant benefit. In this Kaplan-Meier reconstructed meta-analysis of 5 observational studies comprising almost 2,500 patients with moderate aortic stenosis, ejection fraction less than 50%, there was a benefit of TAVR, particularly, in association with a significant lower risk of all-cause mortality compared to clinical surveillance only. But is the evidence robust enough? Actually not yet, because these are retrospective studies. The operator's discretion for SAVR versus TAVR was not controlled. The guideline-directed medical therapy for heart failure were not fully implemented in such studies. There was no consistent method for assessment of the severity of aortic stenosis, and also the crossover between the arms made the intergroup comparisons quite difficult. So the TAVR Unload study, which is an investigator-initiated randomized study, was supposed to be the first study tackling the issue of TAVR in moderate aortic stenosis. This study was supposed to recruit 300 patients, but because of the slow recruitment rate, they only recruited 89 in each arm. For the primary endpoint of MACE and all-cause death, there was no significance between TAVR versus just clinical surveillance. But the quality of life by Kansas questionnaire showed a significant benefit initially, although this diluted by time. And the crossover among the groups between the two arms was actually 50%. So 50% of the patients in the clinical surveillance group crossed over to undergoing TAVR because of the progression of symptoms. We are awaiting the results of 2 important trials. The PROGRESS trial, which will be randomizing 750 patients between TAVR by SAPIEN platform versus clinical surveillance with hard primary efficacy and safety endpoints. And the Evolute Expand trial for the Evolute platform, randomizing also 650 patients for TAVR with guideline-directed medical therapy alone versus guideline-directed therapy without valve replacement. So, is it too early? Well, actually, yes, it is too early, but it's still too close. So the take-home message, the cornerstone of clinical management of moderate aortic stenosis so far is just watchful waiting, probably with shorter time intervals for the echocardiographic follow-up. A paradigm shift is uprising for early intervention in patients with moderate aortic stenosis, especially if they are having reduced ejection fraction. And we have to look to the extravalvular items, the cardiac damage framework, to phenotype the patient that might be eligible for preemptive TAVI. Thank you very much.